Hello, thank you for having me. My name's Pettina. I am the permanent nurse practitioner working at Seymour Health. Seymour Health is a small rural hospital in northern Victoria. We have a 30-bed acute ward, 5-bed urgent care centre, and we also have a 30-bed residential aged care facility. Up until recently, we were relying on our general practitioners to provide us with an after-hours medical emergency service. So they would come in from their clinics during the working during the day, and then after hours they would come and provide us with emergency service when our nurses couldn't deal with the patients and it was beyond their scope. That service was becoming less and less sustainable as the GPs were deciding that they were finding it harder and harder to do that on-call, provide that service for us. So we have now got nurse practitioners doing that for us on the weekends. So the way that we came to, why we needed to have an alternative, I don't know, in Victoria, certainly our rural GPs are getting fewer and fewer, and a lot of them are living in the metropolitan regions. We're only an hour out of Melbourne, and so for us to employ GPs that are living in the area is really, really difficult. Gone are the days, well, certainly in rural Victoria anyway, where your GP lives in the area, brings his or her children up in the area, their kids are playing sport on the weekends, so it wasn't such a problem. Like, the demographic has changed now though, so we for now are looking at our GPs doing their work during the week and then wanting to go home to their families on the weekend, not hanging around at Seymour doing an on-call service for the hospital. Our acuity was also getting higher in the urgent care centre, not our numbers but certainly our acuity, and we were having increasing times where the nurse practitioners, the registered nurses were saying, but the doctors aren't coming in when we call them. And then the doctors were also saying, well, the nurses are calling us unnecessarily. So it worked both ways. And it was becoming unsustainable for us. So we looked at a couple of different, 4 or 5 different options. The first one was, let's look and see if we can get some more medical officers, or at least some locums, and we advertised and we had 4 responses, which wasn't enough to fulfil an entire year's roster. We looked at telehealth. I'd worked in Western Australia previously, where telehealth had worked wonderfully with the support of the Royal Flying Doctor Service. However, we didn't have a metropolitan hospital that was going to be able to support us with the telehealth. We looked at Ripen, and in Ripen, which is the Rural and Isolated Practice Endorsed Registered Nurse, which allows limited administration and dispensing of medications. However, that didn't really fill our needs because there was no referral pathways, they didn't have admitting rights, things like that. However, we did actually say, look, this is still an advanced practice role and it certainly helps within our organisation. So we have actually sponsored 7 Ripen nurses, and they finish at the end of this year, which is great. That will help us. And then our CEO said, well, what are we going to do? And I said, why don't we look at getting nurse pracs in, and they could fulfil this role. And he said, okay, go out and find me some. Challenge accepted. So I put out an expression of interest, and I posted it on the Australian College of Nurse Practitioners website. I also spoke to some other contacts that I had, some personal contacts, our Hume Region Nurse Practitioner Collaborative, and a Facebook site. I'm a bit the same as you. And I had 27 people come back to me and say, yeah, we'd give that a crack. So I thought, okay, let's see how we're going to employ these people. We know that we've got people out there that are willing to do and capable of doing that. If we were looking at directly employing nurse practitioners to provide an on-call service, it was going to be prohibitively expensive. There's nothing in the EBA that really gives us a really clear picture. Given that we required at least 9 nurse practitioners to give us coverage over every weekend for 52 weeks of the year, we decided that we were going to either need to contract 9 individual nurse practitioners, or we could employ a locum service. So during the expression of interest procedure, I was speaking with a couple of nurse practitioners who had actually set up a locum service themselves, and they put in a proposal to us. And so Nurse Practitioner Locum Solutions, NPLS, put in a proposal that said, okay, we can supply you with nurse practitioners every weekend of the year. They'll be fully credentialed and they should fit your needs. So Kathy Torrey, Grenier Lowe and Tash Jennings all formed NPLS, and they are responsible for supplying Seymour Health with nurse practitioners every weekend of the year. And they also are responsible for providing credentialing for all of these people. So all the nurse pracs needed to be eligible to have admitting rights at Seymour Health. They needed, obviously, APNA endorsement as a nurse practitioner, their police record check, those sorts of generic things. But they also need their nurse practitioner specific requirements of an ABN, some insurances. We use an acute and supportive care notation for our drug formulary in Victoria, and that gives us a wider prescribing drug formulary. So we insisted on that notation as well. They also obviously needed a prescriber number. And NPLS then went out and they were looking for their nurse pracs so that they could supply us, and I got back to the model of care development. I spoke to a couple of nurse practitioners that I knew that had worked a similar model previously, and their models of care had unfortunately fallen down. One of them was because they didn't have executive support, and then the other one was because they tried to get their nurse prac as a permanent nurse practitioner, and it was financially unviable. So I also looked at the Department of Health's guidelines and templates for model of care development and business case templates, and I compared it also to our current VMO contract. The next thing that we needed to do was identify the stakeholders, so who was going to be impacted by this model of care. And internally that wasn't such a big thing, because we needed our nursing staff to be aware, we needed our executive and our board members, visiting surgeons, pharmacy providers, people like that. But identifying our external stakeholders just became this domino effect. It's like, what if? And certainly our local GPs were very obviously going to be impacted by this model of care. Our receiving hospitals, Ambulance Victoria, but most importantly our Seymour community. We actually draw from a fairly large community, and these guys needed to be fully aware, and we run a nurse practitioner model of care for the last 9 years actually, and so the community was aware of what a nurse practitioner was and what they could do, but we still needed to make sure that our communication to every one of these stakeholders was really, really thorough and well thought out. So we needed to decide who needed to be told what, how they were to be told it, and and when they were to be told. So we triaged our stakeholders, and the first ones that we decided needed to be aware of this change in practice was our nursing staff. Seymour had lost their birthing service only about 3 years ago, and the first that any of our nursing staff knew about it was when one of the midwives was approached in the supermarket, and they said, and the member of the general public said, "Oh my goodness, we've lost your birthing service," and we're like, "Really? Okay." So we didn't want that to happen again, and so we needed to make sure that we were delivering the right information to the right people in the right format. Part of any nurse practitioner or any nurse-led model of care involves a collaborative agreement. So our GPs needed to have quite a thorough written and signed document of our collaborative agreement. So what was going to happen to their inpatients that they already have admitted over the weekend, and if our nurse pracs were going to be admitting anybody over the weekend, how were they going to hand over that patient on Monday morning? And just things like, our referral processes and pathways and requests to our external providers, two of which are our radiology is an external provider, and also our pathology. Given that we're employing contracting private nurse practitioners into a public health hospital system, our radiology department didn't accept our nurse practitioner request forms, so we did have to include that into our collaborative agreement as well. And next, and absolutely vital to the model of care getting off the ground and being sustainable, which is the most important thing here, is embedding it in the organisation. So we had to, again, like the external stakeholders, our list of policies that needed to be updated and changed was enormous. We went from the permanent nurse practitioner model of care through to transfer procedures, through to emergency procedures, OH&S, orientation, limitation of treatment, admission, discharges, all that sort of thing. And we ended up and having to present to the board, having to get executive support, and we did sell ourselves pretty well, so it wasn't too bad. It was just a lot of work. The administrative process, we needed somewhere for these nurse practitioners to stay over the weekend, and so we ended up finding a council house. They needed logins for and email access. They needed swipe card access. Where were they going to park? And just, the administrative process of things that we hadn't even considered. The orientation booklet, it's a 20-page booklet. We tried to disguise that by putting it into a nice little folder, a little booklet type creation, but we didn't trick them. There's still so much information in here. Most of these nurse practitioners hadn't worked at this model of care, using this sort of model of care, and so they ended up finding actually a really great resource, and I actually find them every now and again on a weekend, still carting their little orientation booklet around. It is a 6-hour orientation process if you haven't been working this model of care beforehand, which again seems quite daunting, but they see it as being supportive, and it has actually served us really well. So settling in, oh my goodness, the first week, our nurse practitioner, so it was Tash Jennings, one of the NPLS partners, and she did 18 hours a day on site. Obviously that wasn't going to be sustainable. So after that first weekend, we went, oh my goodness, what are we going to do? So we went through a whole new education process, both for the nurse practitioners and also for our nursing staff. And we came up with this mantra, and there's stickers all over the place. The NP is on call, not on shift. So these NPs were really obliging. Yeah, sure, I'll come in. And they'll be in and they'll be making the beds and they'll be getting the patients their meals and they'll be doing the dressings and, prescribing and administering the medications. And it's like, okay, so not only did our nurses need to remember that they needed to assess and then give a really good isobar handover, they also needed to for the nurse practitioners to say, all right, okay, have you done your assessment? Have you given me an isobar handover? We didn't want our nurses that were already really autonomous and fantastic to de-skill because we now had the nurse practitioners here to do a lot of things for them. So the evaluation process was really imperative and has been a lot of the reason why we've been sustainable. So we have weekly informal feedback sessions. We were having formal sessions every month, but now it's only every quarter. And we act on our weekly data collection and we give out feedback surveys. We've applied to publish and research and present our data. And as part of that, we can also say now that our 2017 first 4 weeks, these were the hours on site in the blue, and our first 4 weeks of 2018, these are our total hours on site. So it's Friday night from 8 p.m. till Monday morning at 8 a.m. So thankfully all that evaluation and feedback has been working. So last night when I was lying in bed thinking about this presentation, you can tell, I was actually thinking about how this model of care has helped to empower our Seymour Health Nurseforce. So from our enrolled nurses, they're assessing, they're investigating, they're giving really, really good handovers. And our registered nurses, they're excluding differential diagnoses, they're escalating their care appropriately. Our nurse practitioner candidate, we've got one of those, and our ripened nurses, they're being mentored by really, really good, high quality nurse practitioners. And the nurse practitioners themselves are working to the full extent of their scope of practice. They've got high acuity patients and their therapeutics, and they're managing all these people that they otherwise wouldn't have the opportunity to do so. So to keep it sustainable, we've had organisational approval at a multi-department level. We've got that constant feedback which we work on and we act on that as well. We've got continual education and we're constantly collecting data and evaluating it. So when you're developing a model of care, don't include the proposed pay rate in your expression of interest. You can't change it. Know the difference between a collaborative agreement and a collaborative arrangement. And when you're credentialing, consider what you really need and what are the legalities behind that. I'm now going to be attending those business plan workshops at the conferences, not going to tea, because they're really, really important. And Medicare. Please allow at least 40 minutes on the phone every single time, and then expect to get a different answer every single time as well. So, look, we're really happy to share. Thank you for hearing about our model of care. If you think that your GP clinic is struggling to fulfil their on-call responsibilities and needs, then maybe you could give me a call, or you could suggest that they used a nurse-led model of care. You're not going to be disappointed. Thank you.